Beta blocker versus pacemaker, their interaction and impact in CHF. Living with congestive heart failure, CHF, often requires a delicate balance between medication and device therapy. Beta blockers and pacemakers are each vital to treatment, but their interaction can become problematic. This is especially true when a patient with underlying bradycardia receives a pacemaker to support heart rate, allowing for the introduction or escalation of beta blocker therapy. If the beta blocker then overly suppresses the intrinsic rhythm, the pacemaker begins pacing frequently, creating a dynamic that can disrupt the heart's natural physiology. This can lead to frustrating symptoms like fatigue, poor sleep, and worsened cardiac function. In this article, we explore the physiological basis of this conflict, its impact on outcomes, and the strategies clinicians can use to break the cycle through careful pacemaker programming, beta blocker management, and advanced pacing techniques. The tug-of-war, beta blocker against pacemaker. The beta blocker works to slow the heart rate. When a pacemaker is present, set to prevent the heart rate from dropping below a certain level, the beta blocker's effect on heart rate is counteracted by the device's pacing function. This can lead to a situation where the patient doesn't achieve the full heart rate lowering benefits of the beta blocker, while still experiencing its potential side effects, such as fatigue and sleep disturbances. The pacemaker is essentially working harder to override the medication's effect on the heart's natural rhythm. How this interaction can lead to fatigue and insomnia. The constant override of the heart's natural rhythm by the pacemaker, driven by the beta blocker's suppressive effect, can be perceived by the body as unnatural and inefficient. This can manifest as increased fatigue. The heart's mechanical and electrical activity might not be optimally synchronized under frequent artificial pacing compared to a more natural, albeit slower, rhythm. This can lead to a feeling of being constantly run down. Disrupted sleep. The artificial rhythm and the body's attempt to adjust can interfere with normal sleep patterns, leading to insomnia, difficulty falling or staying asleep, or non-restorative sleep. Reduced perfusion. Even with a maintained heart rate, the overall cardiac output and oxygen delivery might not be optimal if the heart's natural response to exertion is blunted by the beta blocker and overridden by the pacemaker. This can contribute to feeling short of breath or lightheaded with activity. How this tug-of-war worsens heart failure and creates a vicious cycle. The interplay between the beta blocker and the pacemaker, leading to symptoms like fatigue and insomnia, can contribute to a detrimental cycle in CHF. Limited optimal dosing. The debilitating side effects of the beta blocker might prevent the patient from tolerating the optimal dose needed for maximal neurohormonal blockade and long-term benefit. This compromises the disease-modifying potential of the medication. Deconditioning. Severe fatigue reduces physical activity, leading to cardiovascular deconditioning and worsening heart failure symptoms, including reduced exercise tolerance and increased shortness of breath. Neurohormonal imbalance. Chronic insomnia can trigger stress responses that counteract the beneficial effects of beta blockers, potentially worsening the underlying heart failure pathology. Impaired quality of life and adherence. Significant fatigue and poor sleep reduce overall well-being and can hinder adherence to the complex CHF management plan, leading to missed doses or discontinuing vital medications. Impact on longevity. The tug-of-war between the beta blocker and the pacemaker, leading to chronic fatigue and insomnia, should not be dismissed as merely affecting quality of life. These seemingly non-cardiac symptoms can have significant implications for the long-term health and survival of CHF patients. Accelerated disease progression. The inability to tolerate optimal doses of beta blockers due to side effects means the patient may not receive the full neurohormonal blockade necessary to slow the progression of heart failure and prevent adverse cardiac remodeling. Clinical trials have consistently shown that achieving target doses of beta blockers significantly improves long-term outcomes in CHF. Increased cardiovascular risk. chronic sleep deprivation and persistent fatigue are linked to increased inflammation, sympathetic nervous system activation, and endothelial dysfunction, all of which contribute to a higher risk of adverse cardiovascular events, including arrhythmias, heart attacks, and stroke. Decline in functional status. Severe fatigue leads to reduced physical activity and deconditioning. Lower functional capacity is a well-established predictor of poorer outcomes and reduced survival in CHF. Poorer adherence to therapy. When patients experience significant and unresolved side effects that severely impact their daily lives, they may be less likely to adhere to their prescribed medications and lifestyle recommendations, undermining the overall management of their heart failure. Increased morbidity and mortality. Studies in heart failure populations have shown that both poor sleep quality and significant fatigue are independently associated with increased hospitalizations and a higher risk of mortality. The chronic physiological stress imposed by these symptoms can contribute to a faster decline in cardiac function and overall health. Managing the tug-of-war. Strategies for optimization. Successfully navigating the interaction between beta blockers and pacemakers requires intricate assessment and a multifaceted approach. The decision to adjust pacemaker settings, particularly raising the lower rate limit, LRL, is a highly specialized maneuver undertaken only after careful consideration and typically by a cardiologist or electrophysiologist. It is crucial to understand why and how this is done, as improper execution can indeed exacerbate symptoms and worsen outcomes. 1. Thorough pre-adjustment assessment. Confirm symptom etiology. Before any change, the medical team must be reasonably certain that the patient's fatigue, dizziness, or other symptoms are indeed due to profound bradycardia from the beta blocker, and not other causes, e.g., anemia, deconditioning, depression, sleep apnea, or other medication side effects. Overview pacemaker diagnostics. A detailed interrogation of the pacemaker is essential. This includes reviewing section percentage of ventricular pacing. High percentages of ventricular pacing, greater than 40%, are concerning, as they can indicate pacing-induced cardiomyopathy or dysynchrony. Section intrinsic heart rate trends. Understanding the patient's native heart rate patterns provides context for how much the beta blocker is suppressing the rhythm. Section lead impedances and thresholds. Ensure proper device function. 2. Strategic and cautious pacemaker reprogramming. The rationale for cautiously increasing the pacemaker's lower rate limit, LRL. The primary goal of beta blocker therapy in heart failure with reduced ejection fraction, HFrEF, is to achieve optimal neurohormonal blockade, which has been consistently shown to improve long-term survival and reduce hospitalizations. However, if beta blockers induce severe, symptomatic bradycardia, e.g., resting heart rate significantly below 50 to 60 bpm, accompanied by fatigue, dizziness, or presyncope, a patient may be unable to tolerate the necessary dose, or even any dose, of this vital medication. Section. In such scenarios, a cautious increase in the pacemaker's LRL is considered as a strategy to section. Provide a safety net, ensure the heart rate does not drop to dangerously low, symptom-inducing levels. Section. Enable beta blocker titration. By providing a floor for the heart rate, it creates a window of opportunity to slowly and incrementally increase the beta blocker dose to a therapeutically effective level, which might otherwise be impossible. This is about enabling access to a life-saving medication. Section. Improve symptomatic tolerance. By preventing profound bradycardia, it can directly alleviate symptoms like severe fatigue and dizziness attributed to a very slow heart rate. Incremental LRL adjustments. If an LRL increase is deemed necessary, it is done in small increments, e.g., from 50 bpm to 55 bpm, then to 60 bpm, rarely higher than 60 to 70 bpm for CHF patients unless clinically indicated for other reasons. Abrupt, large increases are generally avoided. Continuous monitoring. patients are closely monitored for their symptomatic response, vital signs, and, ideally, through pacemaker interrogation to observe the pacing burden, percentage of paced beats. Prioritizing pacemaker optimization features, crucial to minimize problems. This is paramount. Section Minimizing Ventricular Pacing, MVP, Algorithms. Many modern pacemakers have algorithms, e.g., Medtronic's MVP, Abbott's Rhythm IQ, Boston Scientific's AAIDDI, designed to reduce unnecessary right ventricular pacing. They constantly monitor for intrinsic conduction and only pace the ventricle when truly needed. Activating or optimizing these settings can help reduce the override effect and promote a more physiological rhythm. Section Problem If not used properly, if the LRL is increased without activating or optimizing MVP features, and the beta blocker continues to suppress the native rhythm, the pacemaker will pace the ventricle nearly 100% of the time. This frequent right ventricular apical pacing can lead to ventricular desynchrony, where the left and right ventricles contract out of sync. This can paradoxically worsen heart failure symptoms, reduce cardiac output, and potentially contribute to the progression of pacing-induced cardiomyopathy over time. This directly leads to more fatigue, worse exercise tolerance, and could indeed cause more insomnia due to the unnatural rhythm. OAV Delay Optimization. Fine-tuning the delay between atrial and ventricular pacing, AV delay, helps ensure optimal ventricular filling and contraction. If the LRL is increased, and pacing becomes more frequent, a suboptimal AV delay can exacerbate inefficient cardiac function. O-mode adjustments. Depending on the underlying rhythm and patient needs, adjustments to the pacing mode might be considered. 3. Careful beta blocker management. The goal is not simply to pace the heart faster, but to enable the optimal beta blocker dose. Titration with caution. After an LRL adjustment, the beta blocker dose can be cautiously increased. If symptoms recur or the pacing burden becomes excessively high, the beta blocker dose might need to be stabilized or even reduced again. Balance. It's a continuous balance between achieving the benefits of beta blockade and minimizing pacing-related side effects. There is no one-size-fits-all optimal LRL, it's patient-specific. Beta blocker selection. While all beta blockers slow heart rate, some might be better tolerated in certain individuals. For instance, carvedilol has additional alpha-blocking properties that can help with vasodilation, while metoprolol is more cardioselective. The choice often depends on individual patient factors and tolerability. For consideration of other CHF therapies. If beta blocker tolerance is an ongoing issue, clinicians may lean on other guideline-directed medical therapies, GDMT, that offer neurohormonal blockade or other benefits with less impact on heart rate. NIs, angiotensin receptor neprilysin inhibitors, e.g., sacubitril/valsartan. These are powerful agents for CHF with reduced ejection fraction that primarily affect blood pressure and fluid balance with a generally neutral effect on heart rate. SGLT2 inhibitors, e.g., dapagliflozin, empagliflozin. These medications have emerged as foundational CHF therapies with modest BP-lowering effects and generally no significant impact on heart rate, making them excellent choices in this scenario. Proactive pacemaker implantation. In some patients with severe bradycardia that precludes or significantly limits the up-titration of crucial beta blockers, a pacemaker might be implanted specifically to allow for optimal beta blocker dosing, thereby improving long-term outcomes. 5. Patient education and empowerment. Symptom reporting. Patients should be educated on the importance of reporting any new or worsening symptoms like fatigue, dizziness, lightheadedness, or sleep disturbances to their cardiologist promptly. Adherence is key. Emphasize that beta blockers are vital for long-term CHF management. Patients should never discontinue or alter their medication dose without direct consultation with their healthcare team, even if experiencing side effects. Lifestyle adjustments. encourage good sleep hygiene practices, consistent sleep schedule, dark quiet room, avoiding screens before bed, regular light exercise, as tolerated and advised by physician, and managing other factors contributing to fatigue. 6. Considering physiological pacing modalities, his bundle pacing and left bundle branch area pacing. While conventional right ventricular, RV, pacing, especially at the apex, can lead to ventricular desynchrony and worsen heart failure over time, known as pacing-induced cardiomyopathy, newer physiological pacing modalities aim to activate the ventricles more naturally. These approaches may be considered for patients where traditional pacing is problematic or insufficient for optimal heart failure management, or even as a first-line therapy in some cases. His bundle pacing, HBP. Mechanism. HBP involves placing the pacemaker lead directly into or adjacent to his bundle, the heart's natural electrical highway. This allows the electrical impulse to travel down the native conduction system, his Purkinje network, to activate the ventricles in a coordinated and physiological manner. Benefits in CHF. Section preserves ventricular synchrony. By utilizing the natural conduction system, HBP minimizes pacing-induced desynchrony, which can improve left ventricular function and reduce the risk of pacing-induced cardiomyopathy. Section narrows QRS duration. It can often correct bundle branch blocks, like LBBB, and narrow a wide QRS complex, similar to or even better than traditional biventricular pacing, CRT, in some cases. This leads to more efficient heart contraction. Section improved hemodynamics. Studies suggest HBP can lead to improved left ventricular ejection fraction, functional capacity, and quality of life in selected CHF patients. Considerations. Implantation can be technically more challenging, and higher pacing thresholds may sometimes be required, potentially affecting battery longevity. Left bundle branch area pacing, LBBAP. Mechanism. LBBAP involves implanting the lead directly into the interventricular septum to capture the left bundle branch or its fascicles. This also promotes a more physiological, rapid, and synchronous activation of the left ventricle. Benefits in CHF. Section high success rate and stability. LBBAP often has a high implant success rate with more stable and lower pacing thresholds compared to HBP, which can lead to better battery longevity. Section effective for LBBB correction. It's particularly effective in correcting left bundle branch block, LBBB, and improving ventricular synchrony, making it a strong alternative to conventional CRT. Section avoids pacing-induced cardiomyopathy. Like HBP, it avoids the deleterious effects of chronic RV apical pacing. Section improved clinical outcomes. Growing evidence suggests LBBAP can improve LVEF, functional class, and reduce heart failure hospitalizations in appropriate patients. Considerations. Require specific lead placement techniques within the septum, and long-term data are still accumulating compared to traditional methods. When these modalities might be particularly considered. Section patients with high anticipated ventricular pacing burden, e.g., those requiring AV node ablation for atrial fibrillation with rapid ventricular response. Section patients with pre-existing heart failure or those at high risk of developing pacing-induced cardiomyopathy with conventional RV pacing. Section patients with left bundle branch block who are candidates for cardiac resynchronization therapy, CRT, as an alternative to biventricular pacing. Potential problems if not done properly, reiterated. Worsened CHF symptoms. High percentage of ventricular pacing, especially without optimization, can induce or worsen ventricular desynchrony, leading to increased fatigue, shortness of breath, and exercise intolerance. Pacing-induced cardiomyopathy. Long-term, high-burden right ventricular apical pacing can itself cause deterioration of left ventricular function in some susceptible individuals. Increased pacemaker burden. More pacing means faster battery depletion, leading to earlier need for generator replacement procedures. Persistent fatigue and insomnia. Even if the heart rate is maintained, a constantly paced, non-physiological rhythm can still be perceived by the body as unnatural and contribute to chronic fatigue and sleep disturbances, defeating the purpose of symptom alleviation. Compromised longevity. If the approach leads to worsened CHF or prevents optimal beta-blocker dosing due to intolerable side effects, the long-term survival benefits can be undermined. Conclusion. The intricate interplay between beta-blockers and pacemakers in CHF patients presents a unique tug-of-war that demands a highly nuanced and personalized approach. The symptoms of fatigue and insomnia, often direct manifestations of this conflict, are far from benign. They can significantly diminish a patient's quality of life, hinder adherence to vital therapies, and ultimately accelerate the progression of heart failure, impacting long-term survival. Effective management goes beyond simply maintaining a heart rate or blood pressure. It requires a comprehensive strategy that includes diligent diagnostic assessment, meticulous pacemaker reprogramming utilizing optimization features like MVP and AV delay adjustment, and careful beta-blocker titration to achieve the maximum tolerated, guideline-recommended dose. Crucially, clinicians must now also consider newer physiological pacing modalities, such as his bundle pacing and left bundle branch area pacing. These advanced techniques offer the potential to deliver more natural ventricular activation, thereby minimizing pacing-induced asynchrony and its detrimental effects on heart function, offering a more complete solution to the tug-of-war. By prioritizing this holistic, patient-centered care, integrating both established and cutting-edge device therapies with optimized medical management, healthcare providers can proactively alleviate debilitating symptoms, improve functional capacity, and enhance the overall prognosis and quality of life for individuals living with CHF.